Hi, my name is Bilal Abid and I am working at University of Texas Houston at Memorial Hermann Hospital. So both CARs and bispecifics have their own niche, have their own space. If a patient in clinical practice has a rapidly progressive disease, for example, a patient with myeloma has extramedullary disease and has clinical progression of disease beyond just biochemical relapse, then that patient would not be a suitable candidate for CAR, primarily because the time that it takes for manufacturing, logistics, sending the cells off and waiting for cells, engineered cells to return, it'll just be long enough time that the patient will not be able to wait. So that patient would be a good candidate for bispecific therapy, provided that that patient had sort of a somewhat reasonable or somewhat robust immune reconstitution profile going into bispecific therapy. Now, going into more granular detail in multiple myeloma, all bispecifics that are FDA approved and commercially available, they all need REMS program mandated with them. That's not the case with non-Hodgkin lymphoma. So glofitamab and epcoritamab are both approved in second-line setting for diffuse large B-cell lymphoma, and mosunetuzumab is approved for follicular lymphoma in the second-line setting. Now, if we just kind of focus on diffuse large B-cell lymphoma as a disease itself, and we compare the two products, bispecific products in that disease setting, if you were to ask me how do they compare with each other in terms of efficacy, I would say pretty comparable. Safety, pretty comparable. Now, they do differ in their dosing regimen, route of administration, duration of therapy. And these three factors would certainly allow the physician and the patient and family to choose the right fit for them. For instance, glofitamab is IV infusion, and it's finite duration therapy. 12 cycles, you're done. And as compared to that, epcoritamab is indefinite, so it continues until disease progression or intolerance. However, it's subcutaneous, so factors such as poor IV access, infusion chairs, lack of care provider, those are some of the things that would play into decision making when we talk about choosing the right bispecific. It's not a home run answer here, but if one were to ponder over choosing one bispecific to start out in the community setting, it would be the one with lowest toxicity. And with that, mosunetuzumab comes to mind. Now, that's already approved in follicular lymphoma setting, but that's undergoing significant investigation to move into more aggressive lymphoma in combination, let's say, with polatuzumab. And the early data shows that the combination of mosunetuzumab and polatuzumab further decreases the immune-mediated toxicities, which is interesting, but good for the patient. So community deployment, I think, would be, starting out with mosunetuzumab would be a good idea, and then ramping up to other bispecific constructs with minuscule level of higher degree of grade 3 and above CRS and grade 3 and above neurotoxicities.